What I want to do, though, at the beginning, just to set a little bit of context for what I'll go through, is to decouple these three words, accountable, care, and organization, to frame this, first of all, in terms of accountability. We don't like it, right? For the most part, it restricts our freedom, our authority. It questions our competence. Why does anybody need to check on me, right? You know, kind of thing. We don't like it, that is, for ourselves, right? Or for what we're responsible for, or for our organization. But it's great for someone else. It's great for the people we supervise. It's great for the unit, right? Well, so we want people, we want organizations to be accountable, but at the same time, there's a little bit of this tension. And I think culturally, we just need to recognize that. And we need to really understand a lot more what accountability is going to mean in this new day and age. Accountability for specifically what, right? To whom? And there's multiple accountabilities. And we haven't talked a lot about those. And they're not always in alignment. They sometimes conflict as well. You know, when you have multiple payers and private and public and so forth and so on. And for whom are we accountable? Including those that aren't even, you know, in our network. Okay, so we really have to, I think, give a lot more attention to this accountability issue, the measurement issues, and should we be accountable for things we can't control? Have a tough population, speak 57 different languages, don't adhere with medications. Why should I be held accountable for that if you can't risk adjust for that, right? Well, the comeback is, too bad, okay? Figure it out. That's your work with the community, work with the school district, work with the, you know, local community health leaders. Expand what it is we're asking you to do. Accountable. Care. Care. What does care mean? How do we redefine care? That's what this is really about. It's about a better job of delivering care, coordinated care, particularly for those with chronic illness. And I wonder, and this may be one of the outrageous things I say, and I'll claim I didn't say it, I don't remember saying this, but I wonder about 15, 20 years from now, 2035, 2030, we look back on 2011 and say, God, how anachronistic. Patient care visits, a patient care visit was the main way of delivering health care in 2011 and certainly in the 20th century. You know, because by then, the advances we will have made in the use of telemedicine and in-home technologies and patient self-management and education and new kinds of care teams and so forth and so on will be so advanced and routine and accepted that what we say now occurs between visits is where a lot of the payoff is. That will become so advanced that the idea of an office visit, it'll still be there, right? But will be used much differently and much less frequently than we do today, and the changes in payment that will accompany that. It's just a thought, just an idea, you know, this office visit, the idea that I call up, or maybe I'm on the computer, can't get an appointment for 6 weeks, get in my car, travel a half hour, if I'm lucky, maybe it's longer. Sit in the office. Nope, doctor's backed up, half hour, an hour. Somebody hands me a paperclip chart. Could you update? Could you check these things off? What are you allergic to? You know, we're transforming to medical records, electronic records, but we're not there yet. Finally get in for 15 minutes and then drive back home, okay? That's the modus operandi for too many people today. So redefining care, the care component of ACO. Organization. What does it mean to be an organization to deliver that kind of care is going to be redefined. Okay, so Grand Junction examples, Billings examples, all of your examples, you are redefining your organizations, network organizations, virtual organizations that will have to get this done. So let me elaborate on that. I'm going to talk about a learning system, and then I want to end with some thoughts I've had lately. And I don't watch David Letterman, but I understand he has these 10 things he does, or a checklist from time to time. So I've got a checklist, of 10 mistakes that ACOs are likely to make and what we might learn from them. And I want to see whether or not you are in the process of making some of those mistakes, okay? And whether or not they can be avoided or whether or not actually you want to avoid them. Okay, there's the triple aim that we're reaching for. We all know that: improved overall population health, improved quality, and reduced costs. These are ideas I want us to think about because they're going to be pervasive in what I talk about. Think coevolution of these new payment incentives and the capabilities to respond to them. That's what I heard from Billings, and I think earlier from Grand Junction and from Lee and some of the other presentations, is the key is this managing risk, but at what stage are you able to take on that management of risk? And so you have historically the payers saying, well, we would go to global cap and so forth, but no one in the area wants to do that. The providers aren't equipped to do that. They don't have the electronic records, et cetera, et cetera. And the providers are saying, well, we would change, if we can get the payers to go along and partner with us. So it's this chicken and the egg. And that's fruitless. We need to think in terms of coevolution of this. Portfolio, think portfolio of different approaches, different ways of providing care, portfolio of relevant measures. Mistakes, important to make fast mistakes and learn from them as quickly as you can. The plan, do, study, act, PDSA kinds of cycles, whatever that means for you. This involves some risk-taking, but prudent risk-taking, and I'll try to talk a little bit about that. The whole idea is to accelerate learning, much as this conference is about. Think and. We need to get away of this either-or thinking. This and, kind of thinking. Measurement and management. You can only manage, as we know, it's a banal statement, but it has profound implications. You can only manage what you measure. But you know what? What you measure still needs to be managed. And we've done some site visits, and they've got measures, and say, oh, that's nice. Oh, 95th percentile, isn't that great? We don't need to worry about the other 5%, and so forth. They don't really manage the data, manage the measures they have. And then how quickly can we spread some of this in the communities and around the country? So these are some of the things we'll talk about. Big lift. There's no question about it. This is one big, heavy lift. Somebody mentioned earlier today the startup costs from the group practice demo is around 1.7, 1.8 million. AHA average estimate 12 million, differs by whether or not it's a single system or multiple system. And originally they thought we might get 175 to 150 in the Medicare shared savings. These are some issues, and I think they were brought out earlier as well. You need access to data on patients' care to know who they are and how to plan that care. And if you can't get it from your payers or you don't have it internally, that's going to be a big challenge for many of us, for many of you. Accepting risk for patients for whom you have no direct control. They are attributed to you, but they're not locked in, and yet you're still going to be responsible for managing their quality and costs. What does that mean for the new kinds of relationships you need to have with other partners, or those that you refer to, or those that your patients choose to go outside of your network? And the ability to meet all of these quality metrics, the 65, for example. So the key idea in all of this is risk. And I came back to California in 1998 to find out shortly before then, a number of physician practices, some of you may remember this, went under, failed absolutely because they couldn't take on the managed care risk of the 1990s. So this is absolutely key. This comes from Peter Bernstein's book, Against the Gods, Financial Management of Risk, but it generalizes. The essence lies in maximizing these areas where we have some control over the outcome. So if you decide to expand your efforts to be clinically integrated, whether you become an ACO or not, what does that mean in terms of expanding control over outcomes that you don't control now, but will need to in the future, while minimizing the areas where you have no control and the linkage between cause and effect is hidden from us. We don't know what causes what. And this goes back to the measurement set. We should only have reliable, valid, accurate measures if we think we understand the cause and effect relationship between the healthcare interventions being able to influence those outcome measures. If that's a murky gray area, that's an area for further research. You don't include that in the measurement set because it has no implications for actions or interventions. So this is the way I kind of look at it. And this is not, the real world is not as stylistic as this. But I think what you heard this morning and what we're beginning to see around the country is the timeline for your ability to manage patient care risk and fit that into organizational models that are capable of doing that. So in the lower right-hand corner, where you will still have largely fee-for-service, this is really these virtual, okay, in the far right, virtual, a lot of small physician practices beginning to come together to begin to develop the capabilities to manage risk. So probably these virtual are the right organizational form in general. And as you go up from the lower right to the upper left there, the IPA, really well-organized IPA, again, Grand Junction may be one example of that. The physician hospital organization advocate, has certainly been a leader nationally in that kind of model, but they're also a multi-specialty group. The Billings Clinic, okay, we have a lot of these. And then the integrated delivery system. And these blur, they're not real neat. The point being, you need those added capabilities that those organizational forms have to go up for full global cap or partial cap, and you can go back down, episode of illness, and so on. So you can chart your own kind of progress on this and match it up with that ability to transition from just shared savings to assuming the downside risk that we're talking about. How do we create this system of learning? This slide just gives an indication, fairly recent data, 2010, Diane Rittenhouse and colleagues at Berkeley and UCSF and New York Cornell Medical College. We've been tracking physician practices for about 10 years now on the ability to implement the chronic care model, basically, to take care of patients with chronic illness. If we go down the column here, and if you're over there, it's there. Actually, at this conference in Charleston, they gave us 2 of these, so I was able to go like this. It was really great. I felt so empowered. But being a dean, you're seldom in that position, at all. So I really enjoyed that. But in any event, if we go down here, are they doing registries and patient reminders and all this good stuff that most of the evidence suggests is at least associated, maybe not causal, but associated with good outcomes? You can see, even for diabetes, these practices here, only about 21% of the practices, over 500 we have data on in the country, did all 6 of those. And the evidence, as I understand, is probably a bundle of these interrelated processes that make a difference rather than one-offs, right? And you can go down the column here, et cetera, and it really gets bad for depression, right? Now go across the row, and here's my point about learning. If you have a registry for diabetes, look at how the numbers begin to fall off. You don't have one for congestive heart failure. If you're doing reminders and these other things for diabetes, you don't do them as frequently for your other patients. And if you get down here in terms of for how many do you do them for all 4 of the conditions, the numbers get really low, as you can see here. And look at this number down here, wherever it is, the 3.7%. First time I presented this, somebody raised their hand and says, I think you have a typo here. No, it's not a typo. 4% of these physician practices in the country do all of this interrelated set of 6 chronic care processes for patients with all 4 of these conditions, 4%. We're going out in the field again this September, and we're going to look at small practices as well as large, and we're going to track some of this kind of progress over time again. But the point is, where's the transfer learning? Okay, it's not going on even within these practices, and this is what has to change and has to be accelerated. There's no magic bullet. There's no secret sauce. But we have identified, and I think others as well in the experiences you've heard throughout this conference, 6 or 7 things that seem to be pretty important and pretty robust. And you can chart your own progress on these, and you've heard some, I think, some excellent examples. The functionality of the electronic health record. And in recent site visits we've done, we've come across a lot of physician practices that really are implementing a lot of this functionality. But the problem now is how to match that up with the hospitals that they refer to, if it's not a closed integrated system, with their IT system, right? Or even some other providers in the community. And so this is where the health information exchange begins to come in, where you can get the hospital, who may be on NextGen or whatever, and you're on Epic, begin to talk to one another. If you cannot persuade your hospital partners to be on the same system and work together with them. So the functionality really is important. Practice redesign, obviously. Systems engineering tools, lean production, the PDSA cycles, and so on. These are very important. Teams, leadership, culture. We've recently, working with some of the people at Dartmouth, have been involved in site visits to 4 of the 5 Dartmouth Brookings sites, Tucson Medical Center, Health Partners in Los Angeles, Southern California, Monarch in Orange County, and Norton Health System, I think it's in Louisville, Kentucky. And these 3 things, I made this slide before these visits, but it was just reinforced. Their movement to teams, again, what was shown earlier in the billing situation, I'm sure in Grand Junction as well, what's at the heart of the patient-centered medical home, the patient-centered health home, is really important. They put together these teams. They understand how to work with pharmacists, social workers, nutritionists, counselors, in addition to the primary care physicians, nurse practitioners, physician assistants. Leadership, in my mind, is the limiting factor in all of this going forward. It's not going to be the lack of electronic health record functionality. That's going to be a big problem. It's not going to be the lack of capital. That is a problem, okay, particularly for small practices. It's not going to be the lack of quality improvement know-how, although we have a lot to learn and still do there. It's going to be the lack of the clinical and managerial leadership to get those other things done. And I worry about that. And alignment of payment incentives, absolutely, it drives all the rest. Strong ties among all the entities. So if I were to boil it down, it's really on those 2 slides as some of the robust properties of moving ahead in terms of more coordinated, higher value care for our patients, for your patients. Some interventions, the fact that we have an evidence base for what's on the current slides, lest somebody think that's just too high level. This is a meta-analysis of effective interventions for diabetes control. And this is reductions in the blood sugar levels here. 26 interventions, and this is why I emphasized teams earlier. All of these are randomized trials, okay, so controlling for a lot of other factors. 26 interventions involving teams, and that got the biggest impact. The little circles here are the mean reductions in blood pressure, and the bars are the confidence interval around the mean estimates here. And they're arrayed kind of in the order. So if you want some guidance about where might the payoff be, but you got to adapt it to your own local context, it's around working on your teams and some of the other things you see there as well, okay? Registries and management systems, care management systems, and so on. And that's a result of a number of trials. So we do have some evidence on this. So let me drill down a little bit on some of the changes required. And I think some of the things you've heard over the past couple of days, and I want to underscore some of these, and also from the Medicare demonstration program. You have to also recognize the need to redesign inpatient care for your patients and working with your hospitals and hospitalists, that workflow and redesign. So if we want to reduce unnecessary, potentially or preventable hospital readmissions, that starts not at hospital discharge, but days before that patient's ever admitted to the hospital. Do the nurses on 3 West know about your care system after that patient's going to be discharged and what they need to do to prepare the patient and their family for what you're going to do for that handoff? Does the hospitalist know that? Most communities, they don't. It's a separation. Voluntary medical staff, admitting a patient, We do what we do well in the inpatient. We discharge them. Yes, we need good discharge instructions, but that's not going to cut it anymore. You have to redesign the entire episode of care over the entire episode, right? And when payment begins to reward your hospitals for the total care margin, not just the inpatient care margin, that is going to force that kind of change in behavior. But until that occurs, we're in this muddled kind of area of uncertainty. Why should the hospital change some of these things if 80% of its business is still the old business model? 20% may be, hey, we're in a bundled payment demo with CMS or a private contractor, but if I'm the hospital administrator, the local CEO, I'd say, well, that's nice, we'll see how it's going to work, but I'm not going to change my whole organization. That's still only 20% of my revenue. So what's the tipping point? Where's the tipping point in all of this is one of the big questions, I think. Care transition management, we need really new models of that. Hopkins is just one example, the guided care model. There are others out there. Physician referral patterns will need to change in many communities. I accept responsibility. Patient wants to go elsewhere, or one of my doctors who's not closely tied in wants to refer to who she's referred to for 20 years. They went to medical school together. I show her data that says, well, you know, you can continue to refer to Dr. Fox, but look at the data. I have data now. She's high cost. Her quality data is no different. She's really high cost. We can't afford that anymore. So now I'm empowered to tell my good colleague, I'm sorry, Sally, but unless you change rapidly, I'm not going to refer any more patients to you. I can't afford it anymore. Your quality, you can't justify it, etc. You change, that's great. If not, I have alternatives. Less true, obviously, in rural areas, much more so in metropolitan areas. So referrals are going to change. Interoperable EHRs is a huge issue, and again, I mentioned that earlier, and I mentioned the need to move from inpatient margin, if you're the hospital, to think about that total care margin under bundled payment. You really need to work now with your surgeons and everybody that's working with them to optimize that care throughout the whole cycle, because up front, risk-adjusted, area wage level adjusted, you're getting $75,000 for that cabbage. That's it. You hit quality metrics, you can do it less than that, shared savings. If not, you're at risk, okay? You got to work together now. It's not hospitals and, versus doctors, it's hospitals and doctors. Promising approaches, increasing patient engagement, the pre-visit planning, the self-management support, the between-visit care that I was talking about earlier, expanding care management through the telemonitoring, nurse telephone management, patient education, heart failure case management. These are all examples. And a lot of these come from the Medicare physician group practice that you heard about earlier, putting together some of what they were able to implement. Care transition teams, timely outpatient follow-up care, sharing of data, medication management systems. The idea of the non-physician providers, their role in planned visits, delegating exams and tests, patient education, and again, the between-visit management. In California, we have a large Hispanic, Latino population. We have a number of promotoras, and some of us are trying to encourage our regulatory climate in the state to allow, with additional training, the promotoras to do more than just some relatively low-level health education and navigation, to actually being able to do some of the preventive tests, screens, exams, and so forth with very targeted training and, of course, under supervision. We need to think differently about the kinds of health professionals we need and the kinds of training they need to get some of this done working with patients. Where is the lifting going to be the heaviest? I think this is where the lifting is going to be the heaviest, and I'm sure many of you are experiencing this now. It's these tripartite relationships. Who's in control? I want you to be accountable, but you don't hold me accountable. What about the idea of shared accountability? Well, for what purpose? To whom are we going to share accountability? How much of it's mine? How much of it's yours? And what role is going to be for the insurers? So this is sort of interesting. The anthropologists have studied some of this stuff, and in terms of models of interaction among people, have described 4 different kinds of models. You might think about this. This is the kibbutz, is one of them. Communal sharing, we get together. High interdependence, I depend on you, you depend on me. A lot of norms of affiliation. We enjoy each other's company. For all of us to have high quality of life, work life, whatever, we need to come together as a commune and define our values and priorities and how we're going to coexist. Equality matching. Think carpools, carpools, taking turns, reciprocity, progressive dinners or whatever, you host 1 month, I'll host the next month, book clubs, where you rotate perhaps in various people's homes. So this is called by the anthropologists equality matching. And then of course we do have the market to handle transactions and relationships governed by supply, demand, negotiation. This is the way we do it now, right? This is big time in healthcare. And there's also a 4th, which is authority ranking, the paternalistic approach. I will take care of you. I'm the mother. I'm the father, etc. We will take care of you. So all of these are ways of interacting. I don't know which one's best. I'm not, but I would bet the dynamics behind these will play out as we move forward around clinical integration, ACOs, and what have you. Just something to think about, stepping outside some of our usual frames. So let me just say what I see as a major issue, and I'll go back to say we are talking about an ACO, is physician-controlled, okay? How do you divide the savings between primary care and specialty care? I think most of these savings are going to be due to reductions in preventable readmissions, reductions in imaging procedures, and things of that sort. That's where the big money is, okay? So the specialists are going to say, the ACO may be, in terms of numbers of physicians and the emphasis on primary care and medical homes on primary care, the savings and so forth, but they're going to be saying, oh, well, that's fine and so on, but look, okay, of those shared savings, we think 80% of it is due to our behavior and our decisions, okay? So this is going to be an issue that will have to play out, and obviously this is where leadership steps up, the culture and norms of the group, making clear the roles and responsibilities from the beginning, and how all of this might work out. But this is going to be a key question if the ACO is physician-centered and controlled, and there's certainly many communities where that makes a lot of sense, and that's probably what it should be, and the hospitals have to figure out what's their role in that. If it's going to be hospital-centered and controlled, and in the Brookings demonstration program, it's very interesting, those 5 sites, there's variance on this. There's some in there that's very much physician-centered, and some that are much more hospital-centered. Will they be willing to sacrifice the earlier question, the short-term revenue, okay, for long-term goals, and forego profits from these procedures and admissions? What are they willing to leave on the table because they are willing to reposition themselves for the future? Okay? So you could go, here's a revenue line here, upward is good. You can stay the course until the apex, until CMS or all private payers in your community say, hey, that's it, global payment or the Independent Payment Advisory Board, we don't reduce costs. They say, well, we're draconian cuts, all payer rate setting, all states. Okay, you can wait until that. You've maximized your revenue, but you better have the capability to change very, very quickly now to manage in that new environment. That's scenario A. Scenario B is the organization that's going along. Yes, we could milk things further, but I see the handwriting on the wall. We're going to make the changes now. We're going to work with the physicians. We're going to redesign care. We're going to lose money. We know we're going to lose money in the short term. We have examples of that. Okay, to reposition ourselves, though, for the future, we'll be in better shape going down the road. And we'll take market share away from our competitors, even though we've left some money on the table now. Well, what's your financial position? How much reserves do you have? Can you afford to do that kind of strategy? Some can and some can't. And how do you convince you know, the board that's been used to healthcare the way we've had it for decades, that you should take that kind of risk, that it makes sense. So there's a book that came out maybe about a year ago now. Is there a third rail? Not either or, but and. Shared models of collaboration, Partners in Health, Jay Crossan and Laura Tolan. And in this, some of us have tried to explore what this is going to mean behaviorally as you move from transactional relationships with voluntary hospital medical staff members in your community to what we call relational. You don't have to employ them. That's one strategy, but you don't have to employ them to get to the relational kind of state. And I'm not going to go through all of these. You have the slides, but let me just focus maybe on the first and the last. So these are the IOM redesign challenges that came out of Crossing the Quality Chasm in 2001, 10 years ago now. This is the way it usually operates, right? Hospitals doing continuous quality improvement, PDSA cycles, et cetera, has a bunch of ad hoc committees working on quality improvement processes. Perhaps the multi-specialty medical group affiliated with the hospital, or maybe a really innovative, relatively freestanding medical practice is also doing some quality improvement work. But, you know, it's like totally disconnected for the most part. And in a relational kind of model required in the future, that just can no longer exist. This has to be totally integrated, these protocols and pathways across the entire continuum. We're going to improve CABG care. We're going to prevent readmissions. We have to start working together. We have to get the office staffs working together with the hospital admitting and discharge staff. We have to get the physicians involved working together. It totally changes how you think about redesigning care over the continuum to get away from the silos. We're not talking about hospital care or doctor care or nursing home care. We're talking about the patient, okay? That's the only eyes, that's the only care continuum that matters now, if the financial rewards are going to reinforce that. And teams, I've talked about teams, so let me go to the last one here. Performance and outcome measurement, so important. So right now it occurs this way. Hospital has accreditation and a bunch of measures. They're separate from ambulatory care. For the first time, beginning to see them on the same page, at least, okay? CMS and others, National Quality Forum. But again, the point about harmonization, okay, and what it's going to take and which of those measures really make sense and how do we know? If you want to start out with 65, fine, but let's experiment and find out where the pay dirt really is, okay? Let's not just assume that. And in the future, we're going to go to this integrative scorecard, a set of indicators used for quality improvement internally and external reporting. This is the portfolio approach of looking at a scorecard kind of an approach. So that's the implications of some of these changes here. So I want to end in the next 4 or 5 slides and open it up for our panel. 10 mistakes that I will throw out there that fledgling ACOs are likely to make. And you can think about these, whether or not you're making them, have made them, want to make them in order to learn, right? Where you don't know, but it's probably going to be wrong the first time. We don't always get right the first time. Number 1, overestimate your ability to manage risk. Okay, we can do that. We can take this on. We can go on year 2. Okay, we need to move quickly. Will be one set of mistakes. Overestimate your ability to implement electronic health records. Most of the evidence suggests it's terribly disruptive, sometimes up to a year, at least 6 to 9 months. Productivity goes down. Physicians, everyone else complain. Of course, after they're implemented, they wouldn't go back. That's the good news, right? But people will overestimate this ability to harmonize. They may have it implemented in their own practice, but to integrate it with other parts of the system will be a second area of mistake. Overestimate the ability to collect, analyze, and report on performance measures. Okay. This will be another area for mistake. Overestimate the ability to standardize and improve care. You know, we did it for 4 or 5 easy ones. We can just kind of roll that out. We can expand it, not taking into account wearing out some of the people that are working on some of this stuff, not understanding how to manage change in terms of when to speed it up and when to slow it down, being reinforced by past success, and so you just charge on, results in some mistakes here. This is a big one then. These are overestimates. This is the failure to balance those interests we talked about earlier. The key stakeholders, the doctors, the hospitals, the insurers, understanding where they're coming from. Some of you may know about private sector ACO development in California involving CalPERS, state insurer, involving Hill Physicians Group, which is a very large, well-organized IPA, about 1,500 doctors, and involving some Sutter hospitals, mostly in the Sacramento area. And when you listen to them, how they put that together, they said, we start out with a lot of distrust. Finally, we got to the point where we revealed to each other our business plans, our strategic plans and our business plans, what we're trying to do. And that, like, you just raised the veil from both sides. And they saw some of the overlap there. And that engendered an awful lot of trust and enabled them to go forward with this rather innovative approach. And they're going to try to roll it out with some other payers in other parts of the state as well. But you need to get to that point of balancing those interests. So mistake number 6, failure to sufficiently engage patients in self-care and informed choice. Okay, reading the literature, we'll do this, that, and the other thing. Maybe you talk to a few patients and so forth, but that's going to be an area for work. Failure to make contractual arrangements with the most cost-effective specialists and other providers. My earlier example of Dr. Fox, okay, no longer can you afford to have providers who cannot put up the measures. The failure to navigate the new legal and regulatory environment. I think you had a session yesterday on that with Feinstein, I believe. And there's a lot that's being talked about. There'll be safe harbors and so forth, 30%, 50%, primary service area, where do you qualify? But I think a lot of that is still going to be moving parts and will have to be addressed, and I think there'll be some stubbing of the toes there as well. The failure to integrate care beyond the structural level, and this is missing the change management skills. Integrate on paper, move boxes around, say you're integrated, but driving it down to the patient. What is different for the patient will be an area in which mistakes will be made. And then finally, this is the race to the bottom, failure to recognize the interdependencies of all of the above. They have a cumulative effect, okay? How can you manage risk without the ER, without some of the other things that you see on the other slides there, and so on? So looking at the interdependencies of all of these will be important as well. So here are some key questions to end on. Ultimately, can accountable care organizations be affordable in the long run? We talk about bending that cost curve, trying to reduce the percentage increase, not absolute reduction, but reduce the percentage increase so it comes somewhat within the increase in our GDP. My own assessment, I'm not very hopeful at all for the next 3 to 4 years that all this activity we're talking about will do that. And I just don't know how much patience we'll have as a country, given the budget deficit and so forth. And the Independent Payment Advisory Board, assume it still exists, will be taking action, and it will be absolutely draconian. There's no question about it. Do you want to spend 25% of GDP on healthcare? Maybe you do because it's your income. It's your revenue. But what about schools, roads, transportation, jobs in other sectors, et cetera, right? We're at 18% now. Remember back in the days when it couldn't go above 10, couldn't go above 12, certainly wouldn't go above 15. It's just going and going and going. We just can't keep it up. At some point, something has to give. And by the way, a sidebar, maybe we can get into this in the panel. It's hard to face up to. When we talk about reducing the rate of increase in costs, we are talking about people's income and revenue in this room. Okay? To face up to that. What does that really mean if we're going to be more effective? Eliminate waste. So you may think you can eliminate some of the waste without affecting the other end of the equation, but the point is there's going to be less revenue You can make it up by being more efficient, high quality, and get your share of the savings and so on. But the whole idea is we have to learn to deliver health care for fewer resources than historically we have in the past. How fast can payment move away from fee-for-service? How quickly can the tipping point be reached? How much momentum are we going to get? How fast? How quickly can physicians and other providers develop the capabilities needed to manage risk, as we heard earlier today? Can hospitals and physicians play nice for mutual gain, for mutual gain? Can we get sufficient clarity on this accountability issue that I started out with? For whom, for what, how, multiple accountabilities, and so on. Will insurers provide sufficient incentives for consumers, patients, to choose more cost-effective ACOs and patient-centered medical homes? So that's the value proposition, value-based purchasing. This is a summary. Incentives, absolutely important. We need to change those. They are being changed slowly, at least, moving away from payment for volume to payment for value. We are moving finally in this country in that direction. It remains to be seen how fast. But you need the capabilities to respond to those incentives. Okay? EHR functionality, practice redesign, leadership skills. It's not going to happen automatically. And most importantly, we need to know how we're doing. We need to measure and manage. And only if all three of these are going to proceed and be in alignment, not only with CMS, but the private payers, are we going to get a higher performing health system, whether it's through something we call ACOs, integrated care networks, care coordination organizations, whatever you want to call them. And thank you very much. And just a brief reminder that our goal is healthier lives in a safer world. And as important as healthcare is for that, we have to remember that's probably only about 10% or so of what contributes to our health. But unless we in this room do a better job of delivering the health care so we could redirect some of the resources towards other things that really improve health, that in the long run will reduce the burden of illness on our fragile healthcare system, then we're in for a big, big problem. The root production of health is in the community. We all know this. It is about the parks, the recreation, the primary prevention strategies, the fresh fruits and vegetables, et cetera, the environment, the air, the water quality, and so on. We know that that accounts much more for the production of health. But our health system has taken up so much resources that we're spending on the other aspects of it, that is something that we need to begin to fix in order to work on the front end. So in the long run, 30, 40 years from now, your children and grandchildren will be in a better environment than some of us are in today. Thank you very much.